For patients who have received all the standard drugs, this could be third line, could be fourth line, depending on how you use your anti-EGF antibodies. Today we're looking at a couple drugs that are approved in that setting. One is Regorafenib and the other is TAS-102. So these are pretty different drugs with pretty different toxicity profiles. The Regorafenib is a multi-kinase tyrosine kinase inhibitor, so it has a lot of the TKI type toxicities of hand-foot syndrome and rash and fatigue, and I think it's kind of a difficult drug to give to colon cancer patients if they're already beginning to have systemic symptoms and they aren't too robust. So I think for the more robust patients, it's probably worthwhile giving them a try of this drug. There's certainly a tail on the benefit that some people really can stay on it for 6 to 12 months and really benefit from it. That would be maybe up to 20% of patients, and particularly with some of the new dosing information from the Accrue trial, I think that it's probably easier to give the drug starting at the 50% dose and then escalating. So I've been doing that a little bit more. The TAS-102 is an antimetabolite that's a little different than 5-fluorouracil, but certainly seems to be beneficial in patients who've gotten a lot of 5-FU previously. And I think there are a lot of opportunities on that drug to combine with irinotecan, to combine with oxaliplatin. We're presenting a poster here at the GIASCO meeting with my colleagues from Yale of a study that we did with TAS with oxaliplatin. And that's tolerated pretty well, and I think there are more opportunities to eventually move TAS into earlier line therapies.